very warm welcome to this session, which will have the topic and the focus on 4D eyes imaging. I think it's a super interesting new imaging technologies. Our spectrum is broadening concerning interventions, and the spectrum of imaging modalities which can be used for these interventions is also broadening. So we have a great and very experienced panel here. So my spokesperson will be Isabel Kerber. She's from the University Hospital in Cologne. We'll have Sergio Berti, who has extensive knowledge about the intracardiac echo. He's from Italy. Federico De Marco, also from Italy. Angel, your name is the most complicated for me to pronounce. Angel Sanchez Ricalde from Madrid. So we have a very experienced panel here, and you can please pose all your questions. Just let us start with one question to you. Who has already experience with intracardiac echo? So please do the poll and use the app, and we come to that a little later. So what we want to do today is to get an overview about the latest imaging technologies we have. So this will implement a little bit and have the focus a little bit on the question, when do we use eyes, how do we use eyes, how do we come to optimized images if we use eyes? So I think we'll have a very interesting session. It will be case-based, so we'll also see a lot of interesting cases. So Isabel, I would forward the micro to you. So for the next...
And first of all, a warm welcome from me as well. Please feel free to ask us questions or use the online platform so to make this as most interactional as possible. I will start with just giving you a very, very short overview of new imaging technologies in structural heart interventions. First of all, I have to say, when we screen patients for mitral valve interventions or tricuspid valve interventions, heart chamber evaluation and also the evaluation of 3D RV or LV ejection fraction is something that we regularly use. And here, AI tools, as for example, this software program from Siemens, can help us immensely with that. This is a 4D heart where we can have a heart chamber evaluation, as you can see, as quickly as that from a 3D volume, and it gives us all the heart chambers, the volumes, and also 3D and also LV and RV ejection fraction in a very short amount of time. With 4D TOE, we are regularly used to having great images nowadays. Even for the tricuspid valve, as you can see here, we are used to having really good resolution, also the full volume, using MPR. This is something that we are quite used to. As well, for example, also with color Doppler. The same goes especially for the mitral valve, which usually is a little more easier to image than the tricuspid valve. So here we are quite spoiled already nowadays. But there are patients, and this is the main topic of our session, where TOE is either contraindicated, which is seldom, but which might be the case in some patients if they had recent upper GI bleedings or they've had recent esophageal surgery or something like that. And we do have risks with TOE. Those risks are very minimal and very low, but still, if we do a TOE, especially in tricuspid interventions, when we slide a lot up and down the esophagus, we risk these patients having oral or laryngeal or esophageal or gastric perforations or lacerations, let's say. And another point is especially true for the tricuspid valve, that the tricuspid valve is sometimes very hard to image with TOE because it's situated in the far field when talking about TOE, and then our resolution usually is more axial than lateral because we are not orthogonal to the annular plane in a lot of cases. And then another point is the leaflets of the tricuspid valve are way thinner than that of the mitral valve, so this all poses significant challenges in imaging the tricuspid valve in TOE. And this is where eyes can tremendously help us in the future, I believe. This is just a quick evolution of the 4D eyes imaging. We started years ago, about around 2000, with just having 2D eyes, and then the great step came when we had the first 4D volumes, which are now even better in 2024 with the Acunef Lumos catheter that has even better volumes also for the MPR that we use and need, especially when imaging tricuspid valve interventions. And I'm really happy and glad that we will have and show you great cases in the next 45 minutes. And I'm really happy to see how you like it and enjoy a discussion with all of you. Thanks a lot.
Thank you very much, Isabel. We might see the poll, if this is possible, just to get an idea who has experience with ICE or not. So I just get a glance on it and, okay, so this is interesting. So the majority obviously has no experience, so the focus will be maybe a little bit when to use it, when it's helpful in your situation during your procedure. But nearly 50% have obviously some experience with ICE. So just one question before we go. No, Federico, you can already walk to the podium. But one question up front: what are criteria where you would say, well, I wouldn't go for in the procedure with TEE at all? So where would you go for an ICE procedure or ICE planned procedure up front?
I think if you don't, what you need is at least one very good image. When we talk about tricuspid valve interventions, you need at least one good image. It may be transgastric. If you have a perfect transgastric view, I think you are probably able to do it with TOE, or if you have a really good transesophageal. But if both windows are really not good, then you should definitely think about it. Because then otherwise we know that the imaging part is so important that it really translates into the outcome. So if we have poor imaging, the outcome might be poor for the patient as well.
Can I add something? I think, this is a good message when you don't have a good transesophageal echo, pull out and use a 4D ICE, but there is some learning curve. We will speak maybe about this later during the procedure. So I think super selective use only in those very difficult cases may pose a problem. So you need maybe to have a lower threshold and you use your ICE in most or half of your tricuspid procedure, and that's when it's going to be super useful in those very hard imaging cases.
Yeah.
Federico, you will give us first insights how to use intracardiac echo on the mitral space.
Yeah, let's start. When and how to use intracardiac echo, for the ICE during mitral TEER. So we know that transesophageal echo is the rule for mitral TEER. It's easy, it's convenient, it's cheap, and I think different from the tricuspid space, it's uncommon, if not rare, to have image quality that makes really an M-TEER procedure not doable. However, there are some contraindications for transesophageal echo. So I'm going to share a couple of cases that I did with 4D ICE guidance, but that's what I want to remark about the learning curve. I am a ICE user for also PFO, ASD, left atrial appendage occlusion. I use 4D ICE for TEER, so I think there is a learning curve, and I want to remark this. Let's see the first case. 82 years old female with permanent atrial fibrillation. She had a very huge hiatal hernia with basically without any contact with the probe to the surface of the esophagus. It was really impossible to have any image from transesophageal echo. She had a mixed atrial function and primary MR with a central severe regurgitation. Medical therapy obviously not an issue. She had heart failure episodes in guideline-directed medical therapy. She is too high risk for surgery because of her age. We could not do transesophageal, so basically we decided to do a TEER guided by ICE and assisted also by transthoracic echo. So the two different imaging modalities at the same time. This is a transeptal puncture on 4D ICE. We check in this case we checked for the height also in an apical 4-chamber view by transthoracic. You see our catheter, moving up here, confirming that we have enough height above the mitral valve. Then we advanced our ICE catheter in the left atrium through the same transeptal catheterization after dilating it with the mitral clip sheath, and this is the kind of images that we are able to obtain. We steer and clock the mitral clip on for the ICE. We decide the right clocking, and again there is in this case an integration between transthoracic and transesophageal. We steer, we approach the mitral valve on short axis. this, we perform the grasping. In this case, is the image quality on for the eyes is good. We also obviously can place the color and assess the echo. We confirmed in this case that the grasping was good for the mitral clip, also on some transthoracic echo windows. We checked for our result, which was good, and then we basically released the clip. This is the fluoroscopy showing the eyes and the catheter and the transthoracic echo probe, and this is the result both on eyes and on transthoracic echo. This other case instead is guided purely by eyes, so no transthoracic echo used during the procedure. The patient is an 82-year-old male. In 2008, he underwent a complex esophageal surgery and gastric surgery for an adenocarcinoma with Barrett's esophagus. He had an absolute contraindication to perform transesophageal, and he had an A2, A3 central and medial, central-medial severe regurgitation due to a prolapse. This is the baseline screening transthoracic echo, confirming the severity of the mitral regurgitation. And we plan to do an TEER with Pascal guided only by the eyes, and we were obviously, we could have pulled out the transthoracic echo if necessary, but it turned out not to be useful in this specific case. This is the transeptal puncture. We advance our sheet on the other side, we dilate, and then we again advance the 4D eyes catheter through the same transeptal access used for the mitral clip. We advance the device we steer it towards the mitral valve. That's mostly a fluoroscopy-based step, so nothing really special about it. We confirm the positioning of our Pascal above the mitral valve in the intended location. We advance it across the mitral valve, and you see this was the previous generation of the Acunav catheter, the volume and not the Lumos. So here the image volume is a little bit smaller, but still it can provide very nice images and confirm an effective grasping of both mitral leaflets. This is the device release step. We basically disconnected the Pascal, and then we checked again for our final result. There is a small residual jet next to the implant, a very minor residual mitral regurgitation. Okay, and this is the final result on transthoracic echo, confirming the good positioning in the central medial area of the Pascal and no significant jet visible on transthoracic echo. And thanks for your attention.
Federico, thank you very much. So for me, it was interesting to see that you combine intracardiac echo with transthoracic. You showed with your second case, it's not obviously necessary in all the cases, but I mean, you have the 3D MPR abilities, so is it, or capabilities, so is it really needed to go for additional transthoracic confirmation of the height above the valve?
Not really. That's just, I mean, you can basically do it only for the eyes. It's, I think, you know, as a general purpose, it's always good to confirm on different modalities. If you are redundant, that makes it safer and better. But you can definitely do a perfect transeptal catheterization only with intracardiac echo. Absolutely. That's because of redundancy.
Another thing you already mentioned is the learning curve. So, I mean, we have maybe 60% here in the room who have no experience. So what would be your advice? You want to integrate intracardiac echo in your daily practice. What would you advise? What should the people do? What do you need as training to really implement it in your daily practice?
Well, I think some formal training and studying on the intracardiac echo views is, you know, just a quick overview that's useful. And then I honestly think one should start from having a lower threshold in using the device. So use it as much as possible so that makes the learning curve faster. When we think of the structural space, we have lots of procedures. I think maybe PFOs are the easiest modality to start using intracardiac echo. Then maybe left atrial appendage occlusion, that also helps a lot. And then maybe switch to AV valve interventions, which require a little bit more of skill, probably. I don't know, what's your idea? I mean, you are all, intracardiac echo users. I think this is an interesting discussion.
Yeah. Maybe Angel, you can comment on that.
I think it's a good question because in my case I learned by myself. So I started with tricuspid field because sometimes I couldn't see well the tricuspid valve using the TEER. So I think that the best way of learning is to do both transesophageal echo and eyes, and to check and step by step. I think is a good learning.
Yeah, my experience as well, because if you are adapted to TE images, then you can learn. If you adapt a new imaging modality, you can switch in between. The only thing you have to learn, you can't use both of them at the same time because they're interacting. Another interesting point might be, especially for the mitral procedures, you need a transeptal puncture. So you, Federico, mentioned you are you're going via the same hole with your ICE probe and position it where in the left atrium?
Close to the roof. So, and obviously sometimes there is interaction with the mitral catheter. So sometimes maybe another transeptal would be recommended in order to reduce the shadowing effect. But that's to me is the most convenient position. Makes it quicker, and if you have a good imaging from the same transeptal axis, that makes it good. Do you have other ideas on this, or?
Yeah, Sergio, this would bring me to the next question for you. I mean, if you need two transeptal punctures, how to do it? Any advice?
It's a good point because to use the same hole is less time consuming, but the main problem is what Federico mentioned, that the possible conflicts of the two devices. So when you move the delivery system of the Pascal, you move at the same time also the ICE probe, so you need to readjust the position continuously. To use the two transeptal puncture is more time consuming at the beginning of the procedure, but you save time during the procedure. And usually we perform the second transeptal puncture from the left femoral vein, and we move the ICE catheter on the right side for the monitoring the transeptal puncture. We do the transeptal puncture usually more or less in the middle of the set of fossa ovalis, and we advance the ICE through the second hole. At the beginning of the procedure, you spend more time, but during the procedure, you have stable imaging, and you work easily during the capture. And
let me ask you a question. Basically, so you're going to have, looking from bottom to the top of the left atrium, you're going to have the mitral valve plane, the ICE catheter, and then your transeptal guiding catheter for the mitral device. Is that right?
Yes. No, Federico, the transeptal puncture for the device is usually in the inferior posterior portion of the fossa ovalis, and the second transeptal puncture for the ICE is more or less in the middle of the fossa ovalis.
More anterior.
Yes, more anterior.
Okay, so they are parallel.
You are not in the same line.
Okay.
So there is not interference between the ICE probe and the delivery system of the device.
How can you decide the precise location with ICE for the second transeptal? This is just to share a learning.
Using the ICE, we advance. After the first transeptal puncture, we keep one stiff wire in the left superior pulmonary vein from the right side. Then we advance a 20 French short sheet, and we use the same side where the wide inside and the ice probe in front of the fossa valis, and from the left side you do the second transeptal punction. Then you switch the ice from the left, and it's done.
Okay, great. I have a very general question actually to all of you maybe. Would you say that ice is manageable in any patient, or have you experienced that there are patients where not TOE, but ice is impossible? Are there contraindications, or what are the limitations for ice? Or is it, you would say, no, that's possible?
Federico.
No, it's right. Anyone, Federico, go first, sure.
No, ice is impossible.
Or limitations, let's say limitations. Or if there aren't any, I mean, great, but I would like to hear it.
Well, I think in some patients finding a perfect resting position for the catheter and having stability of the image quality throughout the procedure might be a little bit more challenging.
Also, the higher probably the atria are.
Yeah,
right?
the wider the atrium, the farther you are from the valve. That makes it more challenging.
Okay.
And yeah, there's sometimes the venous conformation of the leg sometimes it could be a problem. Because to have a good second access sometimes it's not easy, or it could be complex.
Yeah, but it's encouraging to hear, because even if you come to the tricuspid side, so we have much more complications with TE imaging due to shadowing and things like that. So Sergio, you will lead us a little bit into the tricuspid space. So I would like to ask you to go to the podium and present your case and take us with you in the tricuspid world. And meanwhile, since Sergio is bringing up his presentation, Federico, one question concerning the access. Do you always go transfemoral, or is there some situations where you think about a jugular approach?
I mostly do transfemoral. On the same side, same groin, a couple of centimeters away, but same access, and pre-closure with a suture-based system for both accesses. And yeah, that's what I do. I know Sergio goes transjugular, so he's going to show us the other way around.
The problem is what is the best solution for managing the ice probe. One difficulty is if the imager and the interventional cardiologist are working in the same position, you don't have enough room, that you are in conflict. If you advance the probe from the jugular, the imager is in the more familiar position for him, because the situation is quite similar to the TOE, and the distance from the point of insertion of the ice in the jugular and the right atrium is shorter, so the movement and the artifact of the probe are less. So in general, I prefer this second approach. Yes. Go. Okay. Thanks, Nina, for the introduction. And as Isabel mentioned at the beginning of this session, to image the tricuspid valve is challenging for different reasons. First, because the leaflets are thin, the complex apparatus of the valve is extremely difficult to image. Because the position of the tricuspid valve is far from the esophagus, and in the middle between the probe, TE probe, and the tricuspid valve, we have the mitral valve. Sometimes the mitral valve is biprosthetic, is calcified, is fibrotic, so the shadowing effect could be relevant. And finally, because even though we make a lot of effort to have an in-front view of the tricuspid valve from the transgastric, is not usually not possible in all the patients. The perspective of the ice is completely different, because the ice probe is advanced in the right side of the heart. In front of the tricuspid valve, you have to adjust the position of the ice probe, and we have a perfect in front view of the tricuspid valve, as we see in this 3-volume rendering. You see clearly the position of the aortic valve at 5 o'clock, the septum, the posterior and anterior leaflets. Our approach is different, as mentioned during discussion with Federico. We advance the ICE probe from the right jugular vein. The position of the ICE probe is exactly the same from transfemoral, but the conflict between the ICE probe and the catheter of the delivery system of the device is less important. And we publish this approach in detail in this paper, and we changed the organization of our cath lab. The interventional echocardiography is in this position. At the beginning, we had some problem because to manage a catheter in the right side of the heart is familiar for the interventional cardiologist, not so familiar for the imager, but I think that in the future we have to move toward a new professional profile of interventional echocardiographer, and this is the setup of our cath lab. Some important aspects of the imaging of a tricuspid. The MPR is essential to guide the procedure in the tricuspid. The first step is to evaluate the anatomy of the tricuspid valve. We know that the tricuspid has 3 leaflets in 50% of cases, but 4 or 5 leaflets in more cases. So in the red plane, we see an inflow-outflow of the tricuspid valve in the right ventricle. In the green plane, exactly an orthogonal view with the septal and lateral alignment. And in the blue plane, we have a 3D short axis where we see the 3 leaflets. In one shot, we have all information to understand the anatomy of the tricuspid valve. If we add the color to the MPR, we have exactly the position of the jet or the jets, and exactly the relationship with the leaflets, and we can decide the strategy of our procedure. Okay, let's go in the procedure. The first step is to navigate in the right atrium. The end-phase view of the tricuspid is extremely helpful to navigate in the right atrium and to approach the valve. And after that, the MPR provides all the information that we need, the position in terms of anterior-posterior position and septolateral, and the clocking of the device. After that, the clasp check, we see in the green plane the check of the septal clasp, and in this slide the check of the lateral clasp. So we have the position, we have the alignment, and now we move pushing the device in the right atrium. We see clearly the position of the device and the clear detail of the leaflets that are in contact with the device. It's important to analyze all the 3 views because each one provides information regarding the position of the device and the capture of the leaflet, the lateral leaflets, and the capture of the septal leaflets. The relationship between the device and the leaflets are extremely clear. And in this case, we add a second device just to correct the minor residual jet in posteroseptal position. So my position is that the 3 eyes or 4 eyes, depend on the name that we want to use, can provide more consistent imaging of the intracardiac structure because it's not depending on the esophageal position. The 3D MPR provides an excellent visualization of all the structure from multiple angles, providing all the information we need for a good characterization of the anatomy of the tricuspid and for guiding the procedure. And we are looking for the new and incoming technology with a larger field of view for the next generation of the device. Thanks so much for your attention.
Yeah, thank you so much, Sergio. And I think as the next case will also be in the tricuspid space, so we can discuss it maybe together. So, Angel, you brought a case where we see a replacement guided by intracardiac echo. So keep your questions and ask your questions so we can post them right after the presentation.
Okay, thank you, Nina. Thanks to the organizers for having me here. These are my conflict of interest. So this is the case of a 73-year-old woman with mitral mechanical prosthesis implanted in 2005, who had several hospital admissions due to right heart failure. Transthoracic echo showed severe massive TR with dilated RV and normal ejection fraction, and TE showed severe functional TR. But the image quality was suboptimal due to the shadowing of the mitral, the mechanical mitral prosthesis, and the septal leaflet could not be visualized even in the transgastric view. And given that, we used eyes as the main imaging modality to guide the procedure. This is the same view that Sergio showed us now. And after crossing, this is the Vogue prosthesis. And after crossing the tricuspid annulus with the delivery system and an island lead coaxially to the annulus plane, we created a capsule gap. This is the space, a capsule gap, retracting the delivery capsule. And the capsule gap is seen as a white marker on eyes. And it should be positioned below the leaflets of the tricuspid valve and above the papillary muscle, the head of the papillary muscles. Then we assessed the trajectory, the position, and the depth, and in everything was favorable, we proceed with implantation of the valve. Next is to expose the anchors to 90 degrees, and in order to adjust the trajectory, the position, and the depth in order to capture the leaflets of the valve. So we continue to retrieving the delivery capsule, and the anchors flit back, as this image showed. And as you can see, the anterior leaflet is pinned, is outside the valve, is not engaged. So we went deeper and advanced the system to go more anterior and recapture the leaflet. So after repositioning the device, MPR showed a good capture, the capture of the leaflet of the tricuspid valve around the 9 anchors of the valve. This is very important to capture the leaflets around the 9 anchors, and for that reason, it's essential to do an MPR in this kind of the procedure. Next, the ventricular portion of the valve was expanded, and we can, in addition to the MPR, we can do bidimensional images to check the position, to check the height, to check the coaxiality, and both images from MPR, 3D images, and 2D images are good to check that everything is, in this case, the leaflets are inside of the valve. And then by rotating the blue capsule, the atrial capsule, the valve, the ventricular part of the valve was expanded, and the valve was fully released. And these are the final images from eyes that show an optimal position of the valve with a good functioning of the leaflet of the valve. Thank you so much.
And a very nice presentation. And I mean, we've seen something which makes it so obvious why we need multiplanar reconstruction, but the implantation of an EVOQUE valve is 90% multiplanar reconstruction. And this is why it's so important that we get these 3D capabilities nowadays with intracardiac echo as well. So just a question for all of you, just to get an impression. I mean, you are the experts in Europe. A couple of days ago, I spoke to Burkhard Mackinson, who is working in the United States, and he said that he's doing 30% of his tricuspid cases already with intracardiac echo. So what is the amount of patients in your cath labs? Federico, maybe first.
The amount of patients where I use the
Where you use ICE as primary imaging option.
I would say it's 30 to 40%.
Sergio.
I think we are close to 99%.
Oh my God. Angel, you have to beat this.
Taliban.
I think it depends on the complexity of the patients. In tricuspid field, I do in 90% of the case both, because I am more comfortable doing both, because sometimes I can see better the anterior-posterior by transesophageal echo and to see septolateral by ISO. I think it's good to combine both techniques. But if you, for me, for specific complex cases that patients with a mitral prosthesis, aortic prosthesis, pacemaker leads, maybe there are 15 or 20% of the patients that is mandatory to use ICE to ensure a good result.
I think that this is a good point, because if you are familiar with this kind of technology, it's relatively easy to obtain good imaging. If you decide to use the ICE in one case in mania, because it's a complex case, it's very difficult that you are able to obtain good imaging, because there are a lot of tips that we have to learn during your learning curve. So.
Yeah, and we also need your experience, because, I mean, we are coming from a setup where we have an interventionalist, we have an imager, and the imager is running the echo machines. How is the setup? Who's running the NPR? Who is running the ICE catheter? How does it look like in your lab, Federico?
So the catheter from transfemoral is usually the operator who's doing the procedure, myself handling the catheter, and the images are generated by an echocardiographer.
So is there a difference in your labs, Angel, Sergio?
Because in general we use the transjugular approach, so it's the imager that manage the probe, the ICE catheter, and they manage the echo machine. The only cases where we use the femoral approach is when we treat the mitral, because we have to do the transeptal. It is mandatory to use the femoral. So in that case, the interventional cardiologist manage the probe, and the imager manage the echo machine.
Yeah, I do the same. The echographer manage the echo machine, and I manage the catheter.
To be fairly honest, we in Germany have a little bit of a reimbursement problem still with the ICE. So we are not as lucky as you guys to be able to use it.
In Italy also we have reimbursement problems, so
Right,
it's not independently reimbursed. So
Okay,
that
but,
goes
I mean,
into a procedure
Yeah.
bundle package of costs.
Which is really great, because I totally agree with you. We cannot use it once or twice a year and be good at it. So we need to have higher curves. What would you say, learning curves? How many, what would you say, 10 patients with ICE and then you're very good at it? Or what would you say, just to pin it down? What would you say? Around about, or is it 2? I don't know. Is it 2? Is it 20?
So, I
Just
mean,
to begin with.
if you use 2D also in simpler cases, the learning curve for 4D makes it much quicker. That's what so, it's about handling the catheter and generating images. So if you also use 2D, the learning curve for 4D is definitely shorter.
Yeah, that makes sense. What would you say?
Yeah, it depends on your background. If you are familiar with 2D, for example, for PFO or for LA closure procedure, it's relatively easy to move from 2D to 4D.
That makes sense, yeah.
If you start directly with the 3D, for example, for the tricuspid, that is a complex setting, the step is really very, very, very difficult.
I mean, we did not yet touch on one really big pro of ICE. We may use ICE without general anesthesia if we do not use a TOE simultaneously. As you said, and I fully agree, I think in most cases TOE plus ICE is probably the way to go to get good images. But do you think in the future it might be possible that we even get higher or faster turnover times or more patient safety because we don't use general anesthesia or we don't have to use general anesthesia in any patient? Every patient? For Angel. Sorry, I'm sorry, yeah.
Yeah, I think so. I think with in the future we can do it with eyes and without anesthesia, definitely.
Yeah.
But what do you need to do that? Why are not you doing it now? No, in the future, why not? I mean, we have the eyes.
We did it in simple cases for tricuspid. Yeah, maybe in the near future, but for PFO and for other simple cases, we did it. We did it.
Yeah, but let's have a look into the future. So, if you have a wish to the companies, what could be ameliorated? What could be better? Even with eyes. I mean, Sergio, you are out because you're already using it in 100% of the cases. So this question goes to Federico.
Always
to Federico and Angel. There is room for improvement to use the eyes. So what would you like to have?
That's a difficult question. So probably I would like to see a little bit of a wider volume in both angles, 90 degrees. A general, also an image quality that gets closer to what we have on transophageal.
What is your wish list, Angel?
I agree with Federico. I think the quality of the image would be the same as the transophageal echo. And also I have, in sometimes when the right atrium is huge, I think it's difficult to see the tricuspid valve. So maybe there is a room to improve this kind of things, because sometimes I can use it, but the quality, because the probe is far from the tricuspid annulus in the case of tricuspid, and the image is not good. And also I don't know if Federico and Sergio, do you think that there are any differences if you use the femoral right or left vein? Because you use the left, maybe
usually
you go higher.
If we think about tricuspid and mitral, if you go from the left, you are a bit higher.
Yes.
So you use the left maybe in the mitral when you don't have enough height from the right. You consider that axis. So maybe that would put you even farther away from the tricuspid valve. So maybe from right, the angle is usually more favorable, in my opinion.
It depends on the dimension of the right atrium, because if you have a big right atrium, from the right side is more comfortable. Another alternative is to use a steerable catheter, a long sheet steerable catheter. You advance it, you keep so you have the advantage of the steerability of the long sheet and the ICE catheter. So the combination of both, also in challenging cases, you can get good imaging.
Okay, there's a critical question for you. It might be the last one of the day. Sergio, how many TEER procedures on the tricuspid side do you perform if it's 100% eyes? I know you do a lot.
That's the sales department who's asking.
How many cases you do?
How many TEER cases?
For 1 year?
Yeah, within 1 year.
Yes, more or less 20, I think.
Okay, so don't be too critical. I mean, Isabel, so we are both from Germany, and on our wish list would be the cost aspect. So we would like to get reimbursed for the ICE catheter, if it could be on the wish list. Well, from my side, thank you for attending this session. Unfortunately, we have to look at the watch, so we are coming to the end. And Isabel, I would like to have you summarizing what we've learned today and what should we take away.
Okay, first of all, I think we should take away that from now on, every patient does not get general anesthesia, but just eyes. No, I'm just kidding. I think we will see growing numbers of like tricuspid interventions, and also the toolbox has evolved. So I think that eyes will play a big role in the future. And with the higher the learning curve, the higher the cases get, the better we will all get, I think, at interpreting it and also at using it. I think also eyes may help us with patient safety in the future if we maybe not use general anesthesia in any patient, maybe even have quicker turnover times. And I really do think that especially in the tricuspid space, we will have great advantages because challenging imaging scenarios are so critical sometimes and also associated with worse patient outcomes. So I think it was a great session. Thanks to Nina for organizing it. Thanks to Siemens a lot for having this great session with us. And thanks a lot to our speakers that brought so great cases. Thank you.